Good afternoon. Welcome to Preventive Medicine Grand Rounds for December 7th, 2022. I'm Bob Kirkaldy from CDC's Division of Scientific Education and Professional Development, and I'm honored to facilitate and moderate this session today. The Preventive Medicine Grand Rounds is sponsored by the CDC Preventive Medicine Residency and Fellowship and the the Health Resource and Services Administration Bureau of Health Workforce. The PMRF provides 12 and 24-month full-time longitudinal service learning opportunities with senior public and population health leaders to physicians, veterinarians, and nurses who have completed the EIS program or have equivalent public health experience. We use Zoom for the audio and presentation and the question box to post questions. Note that you can post questions via the question box at any point during the talks, and the speakers will work on answering them at the end of the session and at their discretion and time permitting. Note your name may appear associated with the question you posed. If you do not want your name to be associated with your question, please check submit anonymously when submitting. Continuing education credits are available for the live course for up to 1 month after the presentation date, and for the recorded version up to 2 years from the date of the presentation through the CDC Training and Continuing Education online portal. The course code for this grand round is all capital letters, CDC PMRF. If you have questions, please email the Preventive Medicine program at prevmed@cdc.gov, and also intermittently, instructions will be placed into the chat, and they're in the chat currently. Please remember that the views presented by the speakers are theirs alone and do not necessarily represent CDC, the Department of Health and Human Services, or the US government. We will take our usual moment of silence for our colleagues, friends, and families who have dedicated their time, energy, and sometimes lives fighting the COVID-19 pandemic. Today's Grand Rounds will be Preventing Teen Vaping, the Los Angeles story, presented by Dr. Alice Kuo, Professor and Chief of Pediatrics and Preventive Medicine at University of California, Los Angeles. Dr. Kuo's presentation will be followed by a presentation on the national context by Christy Marinac from CDC's Office of Smoking and Health. The presentations will be approximately 1 hour with about 30 minutes for questions and answers afterwards. Please welcome our first presenter, Dr. Kuo.
Hi, everyone. Thank you for having me. I'm very honored to be the speaker today and to share the work during my PhTip year, which I'll explain in a second. As was mentioned, I'm the Chief of Med Peds and Preventive Medicine here at UCLA, and I'm going to be talking about our experiences in addressing youth vaping in Los Angeles. So the outline for my presentation is to give a little bit of the context for anybody not familiar with Los Angeles or California, talk about how we built a coalition to do some of this work, my experiences in the PhTip program, and where we are today, and then finally wrapping up with some lessons learned. So even though I'm going to be talking about Los Angeles, the story starts in San Francisco. And in 2017, the Board of Supervisors in San Francisco passed the nation's first comprehensive ban on flavored tobacco products. I think this was a huge momentous opportunity and occasion to really highlight the potential impact that flavored tobacco products have on our youth vaping experience. And honestly, if you think back to 2017, youth vaping was not on the national radar yet. So the fact that this happened in San Francisco, sort of, kind of under the radar, really underscores the importance of this, this momentous occasion. But not surprisingly, R.J. Reynolds and Tobacco Interest forced a referendum proposition named Proposition E to overturn the ban, and they spent $12 million toward the campaign. I think people in tobacco control were very aware of this, but for those of us living in California and living in San Francisco at the time, this was sort of a unexpected, I think, measure. But surprisingly, and this is what hit the news, was that 68% of the voters upheld the law in June of 2018. And so, this was a great, I guess, if you, as most of us, I think, or all of us on this presentation webinar would be supportive, like this was big tobacco, not winning in this situation. And so I think it's important to understand, if you don't already, this notion of preemption, because I learned about this, why laws have to be passed at the state level, at the local level. And so with tobacco legislation, some states can prevent local communities or cities, which are cities or counties, from passing laws or ordinances that differ from state tobacco control policies. And the CDC tobacco control website has actually great information on which states have what types of laws. And so in California, the California policies allow local communities to pass stricter laws than what the state has passed related to tobacco retail licensure or smoke-free indoor air. And so at the time in 2018, the reason that the San Francisco ordinance was passed in San Francisco County was because the state, California, did not have a statewide ban on flavored tobacco. So, the upholding of the law when through the vote in San Francisco happened in June, and then in LA County, the Board of Supervisors started discussing whether they should introduce a flavored tobacco ban. And the funny thing about California, there's just always sort of like rivalry between the Bay Area and Los Angeles, and who does one first, the other one sort of follows. So this was probably pretty predictable. And this is, I guess, sort of like behind the scenes, what I heard was initially the 5 supervisors were like, yeah, absolutely, this just got passed in San Francisco, we should also do this. But then through the summer, and this is when we realized that like Juul and RJ Reynolds and other tobacco interests started focusing their efforts in Los Angeles County, was that by the end of the summer, a couple of the supervisors were like, now wait a minute, I thought that e-cigarettes actually were valid tools for helping smokers quit. So then the language started changing, and then it wasn't sure that all 5 supervisors were supportive of a flavored tobacco ban. And in the fall, it was, my colleagues in the Department of Public Health said that the supervisors had said that this department had to be neutral on the issue. And I remember when I heard this, I was sort of like, what is public health? What do you mean? There's, it's not a good or bad thing. Like, we all, like, smoking is bad. Like, isn't that what we all think? And so I think, this made us a little nervous here in Los Angeles, that like, because when I thought about, and I don't know, as somebody not in tobacco control, when RJ Reynolds starts to pour $12 million into, a legislation or something like that, what did that actually mean? Right? Where is that money going? I thought it was just all the ads that you see on TV or whatever. But I think it is hiring people to have meetings with influential people like supervisors or like city council members, and sort of sharing with them a different perspective. And so, obviously all of those resources that Big Tobacco has can really lead to really great organization. And so we, to counter that, we have to also be organized with public health and public health allies. And so that was happening, again, sort of under the radar, behind the scenes, between the Board of Supervisors and the Department of Public Health. And then I think, then it became more on the national forefront, right? So CDC released an MMWR report, Notes from the Field, that really raised the alarm about the youth vaping issue. And then the Surgeon General also weighed in that youth vaping was now an epidemic, which, again, now that we've all been through a global pandemic, seems like, but remember, before the global pandemic, this was really kind of big news. And so in those MMWR findings in November of 2018, what was, I think, really alarming was the rate at which high school students were vaping, right? So in 2011, it was only 1.5% of high school students. And then in 2018, just 7 years later, it was 21%. And the big jump happened during 2017 to 2018, where current vaping use among youth increased 78% from, basically 12% to 21%. So this graph, again, from a New England Journal article, actually looks at this rate, and I think it just really speaks to that dramatic increase, and pretty much tracks to the introduction of flavors that are more appealing to younger individuals, like fruit and candy and things like that. And I just put in this slide. I always do this with my trainees, because when we're talking about something that happened again before a global pandemic, it's just like, what else was going on in 2018? Because this didn't even make the list of top stories, right? This issue, I mean, it's big for us, obviously, in public health, but the Parkland High School shooting happened in February of 2018. So there was a lot of attention being paid to gun violence and things like that. Prince Harry and Meghan Markle got married in May, so that there was like a month of all of those types of things in the news. I have to say for myself, the summer of 2018 was really highlighted by the family separation policy at the border, because I was involved in trying to help and marshal resources here in LA County, because half of those kids ended up in LA in kind of ORR shelters around LA County. And so we were dealing a little bit with our Office of Immigration in the Department of Public Health, trying to create resources and make sure these kids got reunited with their family. It was like a mess. And then in November, it was one of the deadliest California wildfires, the Camp Fire, happened. And so I think, just this was the context. And then all of a sudden this report is released, and Jewel was already here in Los Angeles in the summer trying to influence and make sure that we didn't do the same thing that San Francisco did. And so, it was sort of like an alarm at the end of 2018. So because our local Department of Public Health was directed to be kind of neutral on the issue, meaning they couldn't, and they can't usually anyway, right, as a public entity, lobby per se. But I think what was very helpful is they convened an educational session and brought in stakeholders. And so at the time, I was the president of the local chapter of our American Academy of Pediatrics, which is LA County and 6 surrounding counties. And this is why I was involved with the immigration issue in the summer. And by the end of the summer, it was sort of winding down. More of the kids have been reunited, and everybody kind of jumped on board on that. And so then when I attended this educational session with other stakeholders, then I became aware that, this youth vaping issue was happening, and that big tobacco was already in LA County, and we needed to kind of build a coalition. And so what was great is that we had, AAP, which was the American Academy of Pediatrics, American Heart Association, American Lung Association, American Cancer Society, and a bunch of other tobacco-related nonprofits that came together, and we started to organize. We started to meet regularly. In the AAP, I'm happy to say we did put on a community town hall, because I think, as a practicing pediatrician here in Los Angeles County, I wasn't aware of the vaping issues. I didn't even know. I'll never forget. I had a 14-year-old patient, and I see a lot of neurodevelopmental kids, so I see a lot of ADHD. And this 14-year-old, his mom brought him in because he had a huge change in his behavior. He was more combative. He wasn't turning in his homework. It was sort of classic. And then basically what happened was his 14-year-old said, "Oh, Mom, let me talk to him. He's a young man, give him his privacy." And then he shared, he was my first patient. I learned the most about vaping from him. He shared that he had started vaping. He showed me his vape pen. He showed me that there were hoodies that had vape built into the clothing so that you could hide it from your parents. And I was just like, wow. And that was probably in January. And so I said, as a pediatrician, I didn't know this was happening. And I said, parents definitely didn't know this was happening. So we put together this town hall that was for pediatricians, school administrators, and parents. And we had about 100 people come to this community town hall, and it was heartbreaking because some parents had already started dealing with nicotine addiction in their seventh grader, eighth grader, and they didn't know where to turn because pediatricians didn't know anything about it. And the pediatricians were like, go see an addiction specialist. And most of the addiction specialists are for adults. And they were offering things like nicotine replacement without necessarily the behavioral health component. And so it was just sort of a mess. And I think pediatricians were really caught off guard about this. And so we really tried to address some of this. And what started happening, and which was great from our coalition, is that after San Francisco, I think other cities started saying, well, maybe we should address this flavor ban, right? So because of the MMWR report and the Surgeon General warning, like that got into the public conscience in some regards, competing with all the other things that were going on in 2018. But there were starting to be sort of like the early adopter cities. And so just for context, I guess a lot of people know about LA County, but we have 10 million people in our county. And LA City is about 4 million. And then there's actually 87 other cities in LA County, in addition to Los Angeles proper. And there are 1 million of the 10 million that don't even live in a city. They just live in the county itself. And so, we started providing testimony. We started going to local city council meetings and also the Board of Supervisors meetings, because the Board of Supervisors oversees the 1 million people who don't live in a city. And each one of them had to, because we didn't have a statewide ban, right? So each one of them had to address for themselves how they were going to deal with flavored tobacco. And, we would go and provide testimony. And I would say, we all would go to the same meeting. So we got to know each other very well. I was the AAP person, the lung association person was there, the heart association, and so we would all kind of speak to why e-cigarettes or vaping was bad for our, issue. And I felt like I just had the easiest. I was like, it's bad for kids. It's always bad for kids. There's no ifs, ands, or buts about, like, my part was really quite straightforward. And then, I would share some stories about, like, for example, my 14-year-old patient that I learned about all the vaping stuff from, or for example, moms that bring in all the paraphernalia and say, oh, I just discovered this, here you go. And I'm like, what am I supposed to do with all of this? But these local city council meetings, the fact that we showed up, I think, is really important, because the way that, I guess, the big tobacco people would influence the city council meetings is that they would support the tobacco retailers. So many times it would be our group, which were more of the medical providers or, health related people. And there would be a whole, like the 7-Elevens came out in force. They were very organized. That sometimes it would be the regional manager of the 7-Elevens representing like 6 different 7-Eleven shops or something like that. But they would talk about how it was important. They followed all the rules, like all the tobacco products were in in an area where youth couldn't get to, and that adults had rights to, and that if we took away their ability to sell tobacco, that we would be infringing on their ability to make profits. And so it really became like this traditional debate that we kept hearing in every single city that we went to, but we had to go because if we weren't there, then all the city council members would only hear from would be the tobacco retailers. So we had, so it worked. And for me here at UCLA, what was good is that I was able to send trainees as well. So, because there's a lot of meetings, and sometimes, and these meetings can be a little, interesting and tedious at the same time, because you're on an agenda. And if you give the public comment in the beginning under the general public comments, like you can say, oh, I'm speaking to, issue number 21. But that's not going to be heard for a couple of hours. So it was always much more effective to give the comment related to the time the issue was introduced. The problem is there's no time. So there's a city council meeting, and then you sit and wait to where your issue is. And sometimes all the other issues take a long time because there's a lot of people who have comments and discussion and things like that. So even though a meeting starts at 6 o'clock, it was not uncommon that we would be making our comments at 9:30, 10 o'clock or something like that. But it was like, I don't know, because we were a coalition and we would all be there together, I would just bring my laptop and I would work. But, we were very focused and driven to do this. And so I would warn like trainees, and trainees would like the opportunity for their 3 minutes of fame or whatever to give their public comment. And I think it was a great learning opportunity for them to also sit and hear what happens in city council meetings that affect our local communities. But yeah, so that was quite an experience. And Beverly Hills became the first US city to end most tobacco sales. They basically banned all tobacco. They used this opportunity. And the background to this is like, there's like a city manager, I think, or the city attorney who really wanted this to happen. And so they kept kind of putting it here in the Beverly Hills City Council, like, let's be the first, let's be the first. We're going to do this. We're going to do this. So then we heard and we're like, this is great. So we all turned out, and I sent one of my residents who was going into pulmonary. So he's actually a pulmonary critical care fellow right now. And because he was going into pulmonary, he just waxed eloquent about all the damage to the lungs that vaping does and everything like that. But a funny story on that meeting is that there are cigar clubs or cigar lounges in Beverly Hills, and like 100 of them showed up and gave all their testimony about how their cigar club had been there for 50, 60 years, and it was an important pillar in the community. And at one point, one of them said they were an actual community service organization because they provided the service to the community. And so we were really hoping that they wouldn't allow an exemption for these cigar clubs. But in order to pass the whole thing, they did allow these exemptions. So that's why it's most tobacco sales, unless you belong to the cigar club, and then the cigar club is allowed to sell cigars. But otherwise, in the city of Beverly Hills, you're not allowed, there's no sales of tobacco products at all, except for these cigar clubs and I think a couple of the hotels or something. But this was very exciting. And Ruth Malone is a researcher at UCSF, and she's come and given us talks about the tobacco endgame. And I had never even envisioned that this would be possible, that somebody would just, that a city would ban. And so then we really started not just thinking about flavor bans, but, also thinking about secondhand smoke in shared housing. And so these were the subsequent successes from all of that advocacy that we did, or coalition building and attendance at local community meetings. And so I'll just put out there that the one law that California did pass related to vaping or tobacco in 2019 was that for online tobacco purchases, that you have to show an ID to show that you're over the age of 21, and you have to sign for it. So prior to that, kids could order from wherever and it would just be dropped off at the house, and the kids would have access, the parents wouldn't know. So this was the one bill. There were actually several bills that were introduced, but I think it was in Assembly Health Committee that year. There was somebody, an assembly member who was just a very, very strong tobacco advocate, and like nothing could get through. But this one out of like 5 or 6 bills did get through in 2019. And as I mentioned, LA County did pass their flavored tobacco ban in September. And then Manhattan Beach, which is another little city, not like nobody knows Manhattan Beach like they know Beverly Hills, but Manhattan Beach, the mayor at the time was like, I want to be second. I want to be the second city. So I was working with him and talking with him, and I attended all of their city council meetings, and they passed it, I think, 4-1 to also pass a total tobacco ban. And then I'll just mention, because I didn't type it here, but Hermosa Beach was another beach city. And these beach cities are nice because they're like all about green and, banning plastic and things like that. So we were able to like kind of skew our testimony or our comment to say, this is all about health and green communities and, clean air and access to clean air. And so I think these beach communities sort of picked up on it for that reason. And Hermosa Beach, they were set to be third, but they still haven't passed it because then the timing was such that then we ran into the pandemic. And actually this past summer, we reached out to them, to Hermosa Beach again, and said, hey, you remember you were talking about the tobacco ban and now do you want to reconsider it? And their city council is still very skittish on, doing anything that would hurt small businesses because they got hurt so badly during the pandemic. They're like, we don't want to bring up anything that would be seen as anti-business right now. So, but it's on the radar, and we hope to go back and maybe take up and try to get them to be the third city. And then LA City, the city council in LA City they had a hard time. I think that either, there were either big business advocates or maybe, big tobacco got to some of them, but it has been a 3-year process for LA City proper, which is the 4 million people in LA County, to ban flavored tobacco products. So by the end of 2019, all we could say is that it moved out of committee. Like, they had a lot of committee hearings. So some challenges, contentious local politics, as I had alluded to, somehow along the line, like by the end of the spring, 2 cities that were considering flavored tobacco bans, Culver City and Redondo Beach, I think somehow got on the radar, and we knew that there was a lot of big tobacco presence. And we were fortunate, and as part of the coalition, I had nothing to do with this, so I'm guessing like some of the more active members in the coalition was able to retain a public relation firm that really helped us organize and do kind of the background intel on the different city council members. And actually, they would say, okay, we need meetings with this one city council member in Redondo Beach. And so I said, oh, I'm available. And I met him at a coffee shop, and he, I guess, skews conservative, and he was all about choice and personal choice. And so I just met with him to explain the position and how it was affecting the kids. And then he said, oh, well, I think that's the parents' responsibility, but we had these conversations because I guess this is what like big tobacco is doing on the other side. And then Tobacco Free Kids from, I think, DC also helped our coalition by, again, having meetings with city council members. And so it took a lot of meetings, but finally Redondo Beach did pass their flavor ban in September, and then Culver City passed their flavor ban in October. But these 2 cities in particular were like, I felt like those were hard won battles. There was a lot of discussion and reminding, and you kind of feel like you're just saying the same things over again, but like maybe 20 different ways, so that hopefully the city council member is going to hear you. And so in this context, was sort of when I, as like from a career move, was thinking about obtaining preventive medicine training. Obviously, I'm board certified in internal medicine and pediatrics already. I did that training like 20 plus years ago. But we had started a preventive medicine program here at UCLA, and our original program director couldn't continue. So I ended up being the interim program director in 2017, 2018. And then we were cited as a program because I wasn't actually PrevMed board certified. Like, I had the equivalent, I guess, credentialed, but we ended up getting an ACGME citation. And so then I had to say that I was going to be actively looking to get board certified in preventive medicine. And so at the ACPM conference, learned about the CDC program, the population health training program. And so I applied. And because all this I was doing all of this vaping stuff in the context of my role as the AAP president, and I thought, well, let me get into this more and not just do the collation part, but also start looking at policy and analysis and things like this. So this was, to me, like a gift of a year to work on this, because in my usual job as division chief, to be able to focus on a project like this, like to be back in training again, was just really a gift. And so as a PhTip fellow, one of the first things that I did was actually work with my mentor, Tony Guo, no relation, very common last name in Asian, in Taiwan. But he was my mentor at LA County DPH, Department of Public Health, and he is a deputy director there. And we wrote this, I guess it's like a policy brief, it's a RX for prevention. And it was to raise awareness, again, among clinicians in Los Angeles, or in all of California, actually. This is published in LA County, but the publication goes to all like public health departments in California, and just sort of looking at the statistics for LA County, or for what we were seeing. And to, show that among youth, we really needed to step up our attention and put resources towards this. 1 in 10 high school students were current e-cigarette users in LA County, and 83% said that they were using a flavored product, and 61% bought their e-cigarettes from vape shops, because even though they're not allowed, my patients were telling me nobody cards, nobody checks, there's like a flimsy little chain that says no kids allowed, but it's like it doesn't even go across the entire entryway. It's just, so they just would go around, and they weren't being checked. Let's see. And so for my project, I did an additional policy analysis, again with Dr. Kuo, looking at the Los Angeles County Health Survey. And this is a telephone survey fielded every 3 years. It's obviously, the last time was in 2018, and then the pandemic happened, so they're in preparation to field it again. So we're a little behind now. But the last data that we have, this happens every 3 years, and our LA County is divided into service planning areas for the purposes of public health. So make sure that there's at least 500 respondents in each of the 8 service planning areas. And they also incorporate understanding that people sometimes don't have landlines anymore. So they take into account the cell phone only households. And then the survey is translated to like many languages. So we were able to publish this, and I worked with my own trainees. So at the time, Casey Nagel was a preventive medicine trainee, and Denise Nunez is one of the graduates in our program as well. And we were able to publish our findings in the Journal of Public Health Management and Practice, which was actually with a guest editor from HRSA, who was calling for publications or articles from preventive medicine trainees. And the main findings, which we thought were very interesting, was that there was this, there's this argument made that e-cigarettes don't actually act as a gateway drug, that, if you're, it's just, it's like a completely separate kind of substance that people use, and that doesn't mean that they're going to convert into tobacco, combustibles. But what we found was that younger adults were more likely than older adults to be dual users of e-cigarettes and traditional cigarettes. And those who used marijuana in the past month were nearly twice as likely to report using both e-cigarettes and traditional cigarettes. And that the findings supported that e-cigarette use, especially among youth, was likely actually to be a gateway drug into other substances. So this is, in city council meetings, because this wasn't known, because vaping was among youth was such a newer phenomenon, everybody was making all these conjectures. And so this actually allowed us to definitively say, like, we need to stop youth vaping because this can lead to other substances, right? And to be honest, it's true. I think the accessibility to vape paraphernalia and the, nicotine, it's a lot of time to address maybe mental health issues that haven't been addressed in healthcare. And so when I talk to the actual kids who have vaped or about vaping, they kind of fall into 2 categories. One are the kids that are not exactly looking to get high, but, trying to address some issue. But then there was a big category of kids that just didn't know. The number of kids who told me this is just water vapor, I had to say, no, it isn't. These are volatile compounds. Of course, they don't understand what that means. And I would say, it's like inhaling hairspray. Like, it's not water vapor. And so I found that hairspray analogy works well in the clinic, because they'd be like, oh, gross. And I was like, exactly. So don't do it. So for my fellowship project, I think we had one of our activities was to come up with a logic model for our project. And so this is sort of how I envisioned what needed to happen to decrease youth vaping. Obviously doing the town hall meetings and making people aware. We did that in the AAP town hall that I organized. I have not worked very much in schools, although we did have conversations with some schools. And here in California in 2016, we passed a proposition 56, that put a $2 tax on every tobacco product. So that brought in a lot more money towards tobacco control. And a lot of schools did get some extra funding to develop diversion programs and trainings, because all of that had faded away when the traditional tobacco smoking rates had gone down. And then in the government policy perspective, like I was saying, the city council meeting to pass stricter tobacco control ordinances. And so the one area that I definitely was aware of the need for was training for pediatricians to prescribe nicotine replacement therapy, or even address this in their offices during our well child visits. And I because of my role in the AAP, I would talk to groups of pediatricians and I would say, hey, like, are you guys seeing this? Are you guys doing anything about this? And they were like, we're not trained. And I said, okay, well, so then like we need to get trained. We need to deal with this. Oh, well, we'll let the adult providers do this. I mean, I will wag my finger at pediatricians anytime. And I had to say, we can't defer this to the adult providers. Like, these are not 16, 17-year-olds. These are 11, 12-year-olds. And I can tell you right now, no internist is going to see a 12-year-old. And so there really is no choice but for pediatricians to start being more involved in substance use, either diagnosis or management or any of this. And so as a result, during my PhD time, I was able to apply for a Healthy People 2020 grant, very small, $20,000, to do more town halls and trainings for pediatricians. And we introduced vaping resolutions in the AAP to, again, raise awareness. And the AAP is a membership organization of almost 70,000 pediatricians across the country. So to have vaping discussed at the annual leadership forum, will obviously, a lot of people will hear about it. And then finally, and some of this I contributed to, but the good news is that the AAP in 2020 launched an e-cigarette chapter champions program, so that there would be local pediatric experts in each state. And I am the chapter champion for our chapter. There's media and communications training, and sort of like, what are we each doing in our chapter to work on engaging pediatricians and things like that. And so from that, I was able to apply for a contract with our California Tobacco Control Program. And so the good news is we were awarded here at UCLA $2.2 million over 5 years to establish this anti-vaping task force, really focused on LA County. And again, I said, the main thing, and I think one of the reasons they liked our idea was because I said, we need to train pediatricians, because when we're talking about the youth vaping, we're not talking about the older teenagers, we're talking about, preteens even. And so they're like, it is pediatricians who need to be able to identify and treat e-cigarette addiction. And then also, as part of this contract, sort of teaching people, like, so we can't, because now we're funded by tobacco control, we also cannot advocate, but we can educate. And so sort of educate and help to guide people in how to provide testimony at city council meetings for, as I was doing the stricter tobacco control ordinances. So even recently we had a proposition, also Proposition 31, which I'll mention in a few minutes, that even with that, as part of our work for tobacco control, we can't advocate, we can't like overtly state a position. We have to be much more just sort of educating people about it. But then another piece I think, which is good, is developing curricula for health profession schools. So trying to get health providers early, because I am met with a lot of resistance from the older pediatricians who are like, I can't do this. But I think, medical students and residents and, a lot of allied health profession students are more on board with like, yes, teach me, let me learn how to be able to take care of this, because this is a need that we need to address. So in developing curricula, like, it's a lot of negotiation, trying to get some time in the curriculum, but we're hopeful that even, introducing or having a module, and we're hoping to develop like online resources also for these health profession schools for their curricula to incorporate more easily, so that we can, again, broaden the reach of people who can address vaping. So from our work, we have 70 task force members on our anti-vaping champions group. We have representation throughout the entire state through the California Tobacco Control Network, although we are concentrating our efforts here in LA County. And, I think we're in good shape. And I am really proud of the fact that, what started as a meeting, an education meeting, where I was brought in to say this is starting to happen in LA County, to where we can have, a little bit of staff and so working very closely with tobacco control to address youth vaping. Hopefully we're going to be able to make a bigger impact here in my local community. So where are we post-pandemic? This study came out in the American Journal of Public Health, and what we do know is the pandemic did cut access to vaping for a lot of children, a lot of younger, adolescents. And I saw it clinically as well. I mean, unfortunately, there was just a ton of other mental health issues that emerged, but the lack of access and the fact that they were at home with their parents, so they were being more supervised, I think, made it so that, this study looks at the month before lockdown, which was they described as like March 14th, about 2020. They compared, actually, it looks like 2.5 months prior to the 2.5 months after, and there were definitely decreased, e-cigarette use. And this was through a weekly survey that they had been already fielding, and so they were able to just sort of observe the change in the response. So this is great, right? There are some silver linings of the pandemic. And so this is, one of them. And this seemed to be borne out from the notes from the field. E-cigarette use among middle and high school students in 2021 showed that now it's down to 11.3%, right? I had said 21% back in the 2018 report. It's 11.3%. Still a lot of kids, 1.72 million, but almost half of what the peak was. So I would say we're kind of back to 2014 levels about. And then what was sort of the new finding was that before the pandemic, it was this pods and cartridges. And now in 2021, like the whole thing is now disposable, right? So you don't have to have a device and then fill it with like a cartridge or a pod. The whole thing is just, you buy the device, and once you're done, you throw it out and you get another one. And then I think, they started looking at specific flavors. So 85% again are using flavored tobacco of kids who vape use flavored products. The most common is fruit flavor, followed by sweets like desserts, like ice cream, or forget tiramisu and stuff like that, creme brulee, and then mint or menthol. So the latest updates, I would say, since 2021 is that California State did pass during the pandemic SB 793, which was a flavored tobacco ban for the entire state, which was great. Again, a lot was happening during the pandemic, and I think this just was sort of like, again, a little bit under the radar because it didn't make tremendously big news. And so that makes California the second state after Massachusetts. Finally, Los Angeles City, I mentioned, like at the end of December 19, just sort of got that flavor ban out of committee, and it finally passed in June this past year. And then this past November, last month, we passed Proposition 31 to uphold Senate Bill 793 that had been passed in August 2020. So basically, what happened in San Francisco when the Board of Supervisors had decided to ban flavored tobacco sales in the county of San Francisco, RJ Reynolds has spent 12 million to introduce Proposition E to say that that was like not constitutional or whatever. And then here, they did the same thing. This time, Big Tobacco, RJ Reynolds spent 70 million because, California had passed the total ban, and Proposition 31 went to the ballot this past November and passed by a wide margin, almost 2-1 again. And it's supposed to go into effect in 2 weeks. So it got passed last month, supposed to go in. And I just had to add the hopefully word because our next speaker is going to speak to why that is hopefully. But so then I think, and what is really timely is that MMWR put out, another report, the same authors, I think, for this year. And unfortunately, rates are going back up. And I think that's unfortunate, maybe not unpredictable, but that youth vaping and overall tobacco use increased from 21 to 22. And so we have to think about the data because vaping among all students in 21 was 7.6%. And then it rose to 9.4%. So it just, it went down, maybe plateaued, and now it's starting to slowly come back up. And in this report, what was interesting is they started to look at more vulnerable groups, so like targeted, perhaps, populations for intervention. And higher percentages are reported among American Indian, Alaska Native, lesbian, gay, bisexual groups, with a slight higher increase in transgender youth. Higher rates among students reporting severe psychological distress. And then the highest rate was among those with low academic achievement. And I think this is just good information for us in public health to start thinking about if we're going to target our efforts to keep this rate, from going even higher or try to start bringing it back down, that these might be groups that we start with. So lessons learned, obviously, number one, youth vaping is important to address. We really want to, so many of the harmful effects, I think, are still unknown. Before the pandemic, EVALI was starting to be better described. I want to say some of us, especially with our experience here at UCLA, talking with my pulmonology colleagues, there were a group of young adults who had tough times with hospitalizations with COVID, even being intubated for prolonged periods, and didn't have the traditional comorbidities of like obesity or diabetes or things like that. And anecdotally, I was told that, yeah, they probably had, or some of them did have pretty significant vaping histories. So that, to study that and to look at data, to go back and look at those data and try to see if there was a connection, I think would be really important. Coalitions, pooling our resources, can be effective in banning flavored products in local communities. For the amount that Big Tobacco was kind of pouring into communities to stop these flavor bans, like we didn't have like a 10th or 100th of the kind of money that they had, but I would say we were scrappy and we cared and we showed up, and I think that can be really effective. And then finally, really restricting access is a legitimate strategy, whether it's through the bans or like a global pandemic. You see that it does decrease youth vaping. So for the opposing side that says that, oh, it's not about access, it's about parenting or things like that, like there's no argument against the fact that restricting access does work. And so, as I mentioned, targeted approaches might be the way to go as we keep trying to keep these rates down. I just wanted to end with tremendous thanks. Tony Quo, my mentor at LA County DPH, we continue to work on projects, so it's been fun. We were actually fellows together, 22 years ago, so it's been fun to be able to work with him. I have to give a shout out to Tony Neri, my former program director, and my cohort of PH Tip. That's a picture of us when we were in person. In August of 2019. This was at our orientation. And, and then the pandemic hit and it was all going to be virtual anyway, but just funny story, like I think CDC didn't get back into their offices until like 2021. So my diploma or my certificate came like a year late. It was totally fine. It was all good. And then I have to give a shout out to my own group here at UCLA, Denise Nunez, Casey Nagel, Sohini Deva, for doing this work because I'm a chief again. And so I don't have that luxury of being able to spend all my time on one project or a lot of my time on one project. And so my group allowed me to be able to do that during that PH tip here. And then just a shout out to my family. During the pandemic, I think we all appreciated our families a lot more. And these are my two boys. I now have a middle schooler and a high schooler. So I think this topic is even more important for that reason. And so I'll turn it over to our next speaker, Christy Marinak.
Great. Thank you so much, Dr. Cook. Can you hear me?
Yes.
All right, fantastic. Well, I have to fangirl out for just a second to say thank you so much for sharing the story of your work. And, so much of what you have been doing, you could say, well, that's not my job. It's not my responsibility. And I love, of course, at CDC, we always love when you harness and leverage our CDC data. And, we do continue to provide the data and the numbers, but when you share stories of real patient encounters, you're humanizing those data, you're localizing those data. And so there's really just no replacement, I think, for stories and being on the front lines and sharing what you're seeing with actual pediatric clinical encounters. To give credence to the numbers that we put out. So thank you so much. The tobacco industry is always going to have substantially more resources than the public health community. And, you were talking a little bit about the millions of dollars that are being spent, but what we do have are scientists and doctors, and we have science and medicine on our side. And so, when we do it and we show up, we don't need as many dollars, right? So I also think that what you were saying about the idea of choice is so important, and countering that, because really the story of e-cigarette use among youth is one that we've known for a long time from decades of experience in tobacco prevention and control, that young people are attracted to tobacco products because of targeted marketing using themes that we know appeal to young people, like rebellion, being able to hide things from your parents. Then they're hooked by the nicotine. And what we know from our National Youth Tobacco Survey is that more than 2/3 of young people who vape want to quit. So it's really not a choice. So if you want to go to the next slide, Alice, I just want to contextualize the story of these specific sales restrictions on flavored tobacco products within our sort of broader tobacco control toolbox. So we have decades of research that show us foundational evidence-based approaches to preventing youth tobacco initiation, reducing secondhand smoke exposure, and increasing cessation at a population level. And we also now have an increasing suite of strategies at the point of sale that are showing, just like you were showing us, when you remove product availability, you're going to see an impact on youth use, and you're going to see an impact on sales. And I'm going to show you a little bit about the sales data side to complement that story in a little bit. But what I want to do is just contextualize that there's really no single magic pill in tobacco control. It has to be a comprehensive suite of strategies. And we also know from decades of Surgeon General's reports, et cetera, that document the tobacco industry's tactics to counter evidence-based policies. The more potentially evidence-based it is, the more they spend and the harder they fight against them. And when policies, alone, such as raising the age of sale, or putting the onus on parents, et cetera, are less effective if implemented alone, then the tobacco industry is more likely to promote those, right? So we know a lot from them about what's potentially effective by how much energy and financial resources they put into countering. So next slide, please. I want to show you that California is one of a number of communities across the country that have begun to implement restrictions on the sales of flavored tobacco products. Now, this slide shows there's only one state, Massachusetts, that has actually implemented a statewide restriction on the sale of all flavored tobacco products. And when I'm talking about all products, it's really important. I'm including not only e-cigarettes, but also flavored cigars and menthol cigarettes. And flavored cigars and menthol cigarettes are super important because we know that they disproportionately impact the health of African-American populations and youth in particular. Black high school students are significantly more likely to use a combusted tobacco product. And the most commonly used combusted tobacco product in the 2022 National Youth Tobacco Survey was cigars, which are available in fruit and candy flavors. They're sold in packs of just 2 or 3, and are really important, so that when we're talking about flavored tobacco products, we're really talking about comprehensively looking across the range, including e-cigarettes as well as menthol cigarettes and cigars. And so that is what Massachusetts law does. And now California's law, which was upheld by voters in November, also restricts the sale of all flavored tobacco products, again, including cigars, including menthol cigarettes. But there are numerous communities across the country that have implemented restrictions. And, this is the story of tobacco control, that communities are the laboratory for innovative policies. And they often begin in California, where they say, we want to be first, we want to be second, we want to be third. And, and we at CDC learn from communities and innovative policies. And part of our role is to share the story and the evaluation data of the impact of those policies. So next slide, what I want to do is show you. These are data that actually show the sales of e-cigarettes over time. So beginning in 2018, and then you see it spans to July 2022. And what I want to show you with this slide, so you see that it's divided by different flavor types for all e-cigarettes. And you can see there was a real change where that light of their policies against jewel types other than tobacco or menthol. So you can no longer go to a convenience store and find mango jewel pods, right? But so what we saw was a decrease in mint, but later an increase in other flavors than mint and menthol. And the next slide shows you, if you'll scroll ahead, this is the difference, and Dr. Kuo was actually alluding to this from our National Youth Tobacco Survey. It used to be that young people widely cited that they were using e-cigarette devices that were refillable with either pods or pre-filled cartridges. But when those appealing minty or fruity flavors began to disappear, the promotion and marketing and availability of disposable e-cigarette devices in those delicious sounding flavors like Lush Ice and Banana Mint really began to take hold. And so you can see that red line surged up. Those are disposable devices, which have now surpassed the pre-filled and pod cartridges as being the most commonly sold e-cigarette devices. And this is, I will say that one limitation of these data is that they are not available for vape shops or tobacco specialty stores or online sales. So it's not a complete picture, but we think it covers anywhere between 2/3 and 3/4 of the total e-cigarette market. And then the next slide is going to show you what we see in Massachusetts. And sorry, so sorry for what a busy slide this is. I don't expect you to be able, in fact, I can't read the tiny text at the top of that. But what's important to see here is Massachusetts looked just like the rest of the country until they took dramatic action to curb the sale of all flavors other than tobacco flavored e-cigarettes. What prompted them to do that was EVALI. They actually halted the sale of all e-cigarettes for a time during EVALI. And then what they did was they formalized a policy that included a couple of different things. They prohibited the sale of all flavored e-cigarettes except for tobacco flavors. They addressed maximum nicotine levels, and they raised the price through excise taxes on e-cigarettes. And what do they see? They see dramatic decreases in the sale of everything except for tobacco flavored e-cigarettes, which are not commonly used by youth. They also very importantly coupled their efforts with strong enforcement against retailers that were violating the policy and education to retailers. And we have seen that there have been some states that have additional policies, but may not be as well enforced, and they don't see the same impact. So you can't just pass a policy, it also needs to be well enforced. Next slide, please. So what do we know about the overall impact of flavor restrictions on youth use? There has been quite a number of studies that are looking at the California experience, the Massachusetts experience, et cetera. I won't bore you with describing all of those studies, but we'll just highlight that the Food and Drug Administration Center for Tobacco Products recently reviewed 9 studies that use different, quasi-experimental and other methods to look at the impact of a flavor restriction on youth use, and find that overall they conclude that following a flavored tobacco product sales restriction or ban, the use of tobacco products among young people decreases. Next slide. So that's it from me. And I just, again, thank you so much, Dr. Kuo, for what you've been doing. And I look forward to helping out with any questions. Oh, excuse me. You did mention something, and I will say about California. So what's going on in California is a really important story, and it's to be continued. And I encourage you all, if you're interested, to follow along in the news, because this has definitely been a news story. But 2 years ago, California became the second state to ban the sale of all flavored tobacco products. And very quickly, R.J. Reynolds and other tobacco companies funded a referendum that was on the ballot this year. So that delayed implementation for 2 full years of the law. And on November 7th of this year, California voters overwhelmingly upheld the law by more than 60% of the vote. And the next day, R.J. Reynolds filed a suit challenging California's authority to issue that law. And so actually it's going up to the Supreme Court. And although we really are hoping that California will be able to implement this law, which we believe will protect the public's health, it does depend on the Supreme Court's decision whether or not to hear the case. So they will be deciding by December 21st whether or not to hear the case. So more to come about that, but that's why we added hopefully to that. From CDC's public health perspective, there is just simply strong evidence that this policy will help protect the public's health by reducing disparities in tobacco use and preventing youth use. So now I'll go ahead and hand it over to our to Bob. Thank you.
Thank you both for excellent presentations. There is a lot of interest in the question and answer box. So we'll see how many questions we can get to. And
Should I stop sharing so that we're like,
maybe leave it, maybe you can just leave it up. I think it's fine to leave it up, because then if there's, if someone has a question about a specific slide, but also this is a lovely background to look at too. So the first question I'm going to send to Dr. Kuo. Can you talk a little bit about your thoughts on why youth seem to combine the use of e-cigarettes and combustible tobacco products? Is it an issue of maybe higher nicotine content, or any speculation on that?
I'm not sure. My understanding is that the nicotine content is actually, similar. I'm not sure, but I would say that I think we have to think about like the adolescent brain and brain development and access, like how easy it is, and maybe even cost, because I think, these e-cigarettes are actually not cheap. Like you do have to have some resources. So I think there is a little bit of a natural curiosity that if you are using something for a long time, what my patients have told me is just sort of, when you're at a party and things are available, that's when you try something for the first time. So in my well child visits, I actually now specifically for 11, 12, 13-year-olds talk about how to get yourself out of a situation, because I think I heard also, as Christy alluded to, most of these kids want to quit. Many of these kids don't want to start, and it's all peer pressure. Like what I have heard from my patient, it's all peer pressure. You're at a party, someone whips out a vape pen, and first of all, you have to think about the germ, but they all pass it around, and everybody's got a lot of pressure to put on, to take a whatever, like to try it, and if you are not like, strong enough to withstand like being called a loser or, what's wrong with you kind of thing, then you succumb and you try it. And then, that starts happening. And so I'm just going to share with this audience what I tell every patient, all the patients that my patients know, that I will always say this. One patient told me that this happened to him. And I said, how did you get out of that situation? And he said, it was easy. I just told them my mom drug tests. And they said, once I said that, everybody backed up. Oh, sorry, man. And so I tell all my patients, like, if you find yourself in that situation and you just need to get yourself out of it, just say that your parents drug test, because it's possible. And maybe they'll believe that your parents are like that or whatever, but it's just to divert from that. And so I think, stepping up to combustible cigarettes or marijuana or things like that is just the availability or peer pressure more than anything. I don't know that kids are actively seeking out like, oh, I'm going to try an actual cigarette one day,
Interesting. Thank you. Okay, so the next question is about the ban. Do you have any plans, or do you know if Los Angeles County or Los Angeles had any plans to evaluate or quantify the effects of the ban? Because of the possibility of, of it being diverted or, diversion, illegal sales, that sort of thing.
Yeah, no. So Dr. Kuo and I have talked about this, and that's why we're sort of anxious to get the LA County Health Survey administered again, because then it would be 2018 and 2023 data. And so we're hoping to be able to do some analyses like that to evaluate the effect of the ban for sure. There's also a PrevMed group at USC that does a fair amount of tobacco research or vaping research. They have sort of this longitudinal cohort with a number, I want to say 20 or 30 schools in the South LA area. So they have data that we could also, collaborate on to see the impact of the ban. So that definitely stuff that has been talked about, and sort of nice now post-pandemic, we can resume some of those conversations.
Okay, thank you. So here is a comment. Thank you both for excellent presentations. It is a delight to be in flavored tobacco fight with leaders like you. We tobacco-free kids would like to request the cloning of Dr. Kuo in each state where we're now engaging in flavor campaigns. Okay, so this is a question I will kick to Christy to see if you have any knowledge about this. But is there anything regarding Georgia on any initiatives or legal aspects of banning flavored tobacco? And does having CDC in Georgia make a difference?
So CDC doesn't comment on proposed or pending legislation. Dr. Kuo mentioned that we do track state laws on a variety of different topics, including smoke-free, excise taxes, preemption, as she mentioned, et cetera. I am not personally aware of any proposals to address the sale of flavored tobacco products in Georgia. But what I will say is this: the Food and Drug Administration this spring issued a preliminary proposed rule to prohibit the sale of menthol cigarettes and flavored cigars. And that would affect the entire country. And there's really rigorous science and robust evidence that this rule would address tobacco-related disparities. It would reduce youth initiation, particularly of combusted tobacco product use. And FDA has the authority to also address e-cigarette flavor sales more broadly than they currently do with their enforcement against flavors of the pre-filled cartridges and pods. So, when and if these rules do take effect, everyone in Georgia will be covered.
Thank you. There's a few questions around the issue of the outreach, Dr. Kuo, that you had discussed with training of pediatricians and outreach to pediatricians. There was one comment of someone who agreed and said it's hard to find pediatricians who are even aware of nicotine replacement therapy as an option for adolescents, and gave a specific mention that AAP has done a great job on this topic. Someone else asked the question, do either of you know of any guidelines for providing nicotine replacement therapy for youth, for kids, as it's worded?
I think that there are on the AAP website, right? So we actually had a child psychiatrist addiction medicine specialist come talk to our group in our AAP chapter. And I actually haven't had to prescribe nicotine replacement myself, but my recollection is there's sort of like 3 levels of either of like the patch, for example. So you can get a 7 milligram patch, 14 milligram patch, or a 21 milligram patch. And basically you just work with the youth and, understand like it's symptom control, right? So you try the 7 milligram patch, and is it addressed, do they still feel the withdrawal? Do they still feel jittery? Do they feel that they need more? And then you titrate to what they need. And then, over time, the idea that you also want to implement behavioral strategies, and, maybe if they're always hanging out with a certain friend that always is vaping as well, like guide them to maybe not spend so much time with that friend, right? So it's not just the medication, it's medication plus behavior change. And then what Dr. Hunter told us is then you use things like the gum for those craving moments. So you have the patch on in the background, and then they can chew on the gum or whatever if they always feel like craving. I'm just gonna make it up. Like if they hate science and they feel like they always feel it during science class, that maybe they want to surreptitiously like chew on some gum or something. But it's not like a lot of, and thanks Lilian for putting the guide in so the AAP, like that's the gist of it. And I think, when I've talked to pediatricians, it's like everything else, I think it's the fear of the unknown, and then they don't want to learn these skills. But I feel like if you just did it on one child and you were able to get, work with the family, and the parents are just so grateful that someone is even willing to talk with them about it. So, I am willing to prescribe it whenever I have a patient that needs that situation. But at the same time, it can't just be like all of us need to be in the tool bag of every general pediatrician. And Those of us in California might have it a little bit easier because we have all these external factors trying to also decrease access. But, based on the map that Christy showed, like there are so many pediatricians in the middle of the country where I'm thinking lots and lots of their patients are vaping, their parents are pulling their hair out, and they need somebody to guide them on how to address this.
Thank you. So this is maybe a question for either one of you. Do you know of, or are there data on how vapes, e-cigarettes are used with other substances like marijuana or opioids, the effects these may have on children or adolescents? And the person mentions that they've heard of schools that have raised concerns about maybe vapes that have been combined with other substances. But any thoughts or data that you are aware of?
I only have anecdotal. So, it's very interesting. My teenager patients are much more willing to admit to vaping nicotine, and they're much more hesitant to admit to vaping marijuana, although it's legal in the state of California, but not for kids. But, it's not hard. It's kind of the same access wise, I think, for most of the kids in the state. But I do, and I think this is one of the challenges, is that we're not really asking about marijuana. It sort of comes up. So when I talk about vaping, I'm always asking about nicotine, and then I'll mention marijuana, and once in a while it'll come up that they're vaping both. I would say the younger kids, it seemed to me to just mainly be nicotine. Like they know that marijuana is actually a drug, but they don't seem to put nicotine in that same category. But the older high school kids, I think it is sort of like 50-50. They're either vaping marijuana. And I think the reality, I know some of the researchers here on campus that are doing research on marijuana that's funded by the state. But, I think the whole kind of confusion and difference about marijuana just makes it very difficult to have any kind of cohesive research or policies around marijuana. I will say for one of our addiction medicine consortium speakers last month here in LA, we had a talk from the DEA. So there was an agent from the Drug Enforcement Agency who came to speak to a lot of us who were, addiction medicine oriented or whatever. And it was fascinating. And unfortunately, he said everything coming, because we have had, unfortunately, a number of teenage overdose deaths from fentanyl in high schools. And so now the fentanyl crisis is sort of feeling like that end of 2018, everybody's kind of more aware, rainbow fentanyl and stuff like that. And so, I learned so much in that one talk, but the bottom line is everything is laced with fentanyl now because it is cheap, it is easy to make, it comes from chemicals, you don't have to grow any plants or anything like that. And south of the border, they just know that there's a tremendous market up here in the US, and they're just making a ton of it. And he said, and I said, how did it get laced? And the problem is that it is so plentiful and looks like cocaine, or looks like the manufacturers themselves are sort of getting them mixed up. Because, we kind of pointed out, if you're a drug manufacturer and you lace fentanyl into everything, and then your consumers all die of overdoses, that's not a good business model, right? And they were like, well, they don't think that the drug manufacturers are thinking like that, and it's not intentional, it's just messy in the process. So but I haven't heard of fentanyl being laced into the nicotine products, because I think that's actually manufactured in a company here in the US. But I suppose if there was a black market for vapes, then you're taking your chances, I'm guessing. I don't know. That would be my unofficial clinical experiential answer, but I don't know if Christy, you have more.
Yeah, I'm not aware of data on fentanyl in e-cigarette vape devices. What I will say is, to answer the earlier question, there is data from the National Youth Tobacco Survey and other surveys of youth showing a sort of high prevalence of co-use of nicotine and marijuana. So that continues to be a concern. And then also the Valley outbreak, I think it's important to note that primarily patients with EVALI, were using THC containing vapes obtained from informal Black market sources. And so really, it is dangerous to acquire vapes that are, not from a store. It's dangerous to acquire vapes anyway. But what the lesson from EVALI in particular was about Black market products. And I would say that in the current environment of ubiquitous fentanyl, that is something to be cautious about.
Thank you. Excellent. So a few questions that I will cluster together. It sounds like there's interest in the outreach to pediatrician domain. So there's a few questions that link to essentially lessons learned for if other people are going to do something similar. There's someone who asked about whether incentives were provided to providers. I think also part of a larger question of, are there ways, are there ways that you've learned to sort of engage also some of the providers? Sounds like, admittedly challenging, but any lessons learned. And then someone else posted a comment that they're part of the Tobacco Prevention Task Force in Texas. And have sometimes had challenges sort of getting into the door of providers, getting their attention. And so just, was asking for any suggestions for, how to engage with providers, how to get in the door, who to speak to, how to get attention.
Yeah, no, that's a great question, because that's like sort of the focus of our contract with the tobacco control project. It has been challenging, and challenging even more so now post-pandemic. So, when we made the proposal, we had really good success with our town halls. Again, doctors will come for, it's weird, but doctors will come for free food. But, we would have a town hall, we would feed them, we would go, have a nice restaurant or whatever and give the presentation, and they're there with their friends. And so there's a little peer kind of like pressure, like, oh, I'll do it. Okay, well, then I guess I'll do it. That social aspect of physicians is really important to get anybody to do anything new. And so post-pandemic, it's been very, very difficult. All the providers, like right now, not the time to ask. We're in the middle of the worst pediatric respiratory winter. But, maybe in the spring, like what we have tried to do, honestly, is focus on the trainees, because the trainees still need training. And so pediatric continuity clinic, and then you'll get their attending preceptors in that way. And so then the faculty are a little more open-minded about needing to get trained, because the residents want to know how to do this. So that's been one strategy that we focused on this year when we couldn't get any practices, whereas prior to the pandemic, we were able to get more practices. I think it's still sort of like waiting for us to get back to more in-person meetings, feeding them in person, bringing lunch into the office, because I think emails and Zoom aren't going to cut it. I have no other, I guess, brilliant ideas past that.
Right. My guess too is becoming, you're right, coming into this winter, but even coming out of COVID, a lot of providers are very tired.
Yes.
And probably cognitively are stretched then too. So.
Right.
Okay, well, that's really useful context, especially thinking about the trainees and getting that.
Yes.
Someone else raised about, and I think it's something piggybacking on what Christy raised in terms of approaches that have evidence, approaches that maybe have less evidence, but different approaches that people have used. Someone asked about the maybe effectiveness, or just if you know of school districts that have consequences if caught with vaping at schools, for example, as a prevention strategy, or secondary prevention, if that sort of punitive approach with people, children or students caught with vaping supplies at school, whether that's an all effective approach.
Yeah, I can chime in, and then maybe Alice, if you have something to add, I'd welcome hearing what you wanted to say. So we at CDC, we do get asked, and we fund tobacco control programs in all 50 states, territories, tribal support organizations, et cetera. And this issue of how to address youth tobacco access in the school is a really delicate one, right? Because young people are accessing products that are often illegally sold to them by retailers, by adults, right? They are using products that have been marketed using tactics that we know appeal to youth, and they are highly, highly addictive. And so, there are some resources available that encourage and have details about how there can be alternatives to discipline in this issue, so that, we can approach these young people, many of whom want to quit, with compassion. There are some deterrent strategies and strategies that may have a primary prevention sort of as a warning, including that some states that have metal detectors are actually also able to confiscate e-cigarettes while they're also looking at weapons. There has been the use of vape sensors in bathrooms. I think that with schools that are facing really lots of vapes, that they want to have some disciplinary tools at their disposal. We certainly understand that, but given that this is an issue that is really threatening health and that many young people want to quit, we can put I can share, there's a document about alternatives to discipline that the Public Health Law Center put together that is specifically for schools that I'd be happy to share.
So in some of the coalition work that we were doing, I did have the opportunity to consult for Beach Cities Health District, which is a public health district here in LA County, and they kind of support 3 different beach communities. And it was interesting because 2 of the communities, Redondo Beach and Manhattan Beach, did want to address this, again, pre-pandemic. And one did it much more comprehensively, bringing in like lots of training, parent education, and kind of what I would consider like a good way, like a public health way, and sort of raising awareness, being compassionate, and actually the local law enforcement were involved in these efforts. And one police officer who's their diversion police officer or something, she also said, don't criminalize this. Like, these are kids and they need they need support, they need resources, their families need help. Like, you criminalize and you suspend and you expel, then that going nowhere, really. The other school district kind of took that approach though, and I spoke to the principal about that, and he says, oh, we don't have a vaping problem. And I was like, well, but your own students say that they know which bathrooms it's at and stuff like that. Like, so the first school district did implement the sensors in the bathrooms, and every time it goes off, someone goes to look and try to, just catch, or at least the presence of the sensors is, a deterrent. The second school district said they didn't want to put in the sensors because because it would be false positives, and they didn't have the staff, and it was going to be a waste of time. And literally this principal's attitude was, the first 6 weeks of school, we have a ton of suspensions because it's the freshmen who don't know, like, that they're not supposed to do this. And then, we suspend them, we catch them and all that kind of, and then 6 weeks later, there's no problem. And I said, do you honestly believe that they stopped, or they just figured out how not to get caught? And he said, it's not my problem. As long as I don't see it, as long as they're not caught, so I think the bottom line to me is you have all different kinds of school administrators and you have all different kinds of principals who are willing to put in the effort and do all that programming, and others that are just like, don't ask, don't tell, or whatever. Like, just, if I don't see it, then I don't care. And so I think that that's kind of the reality, and that's why there's not going to be one solution, because it's so person dependent.
Right. And it sounds like, from what you're both saying too, it sort of fits within the substance substance use rubric paradigm that a lot of the public health and medicine and society is moving towards more of helping to provide services, helping to support people to get off of them, taking it from a public health harm reduction, I think, good perspective. Okay, well, we are almost out of time. I want to offer tremendous thanks to both of our excellent speakers. And I also want to offer many thanks to Lillian Yang, Rich McCord, Gabby Collins, and Laverne Bates here at CDC for all of their hard work organizing these sessions. So please join us for the next Preventive Medicine Grand Rounds on January 11th, 2023, which will address the use of electronic health data to improve population health. Have a great rest of your day.